Usually when we talk about getting a medical diagnosis, there's this, you know, expectation of precision.
Right, yeah, like structural engineering or something.
Exactly. Like you fracture your radius, the x-ray shows that jagged white line, and the doctor points to the screen and says, well, there it is.
It's very binary.
Yeah, broken or not broken, it's safe. But step into the world of neuromuscular medicine, and that x-ray machine is essentially useless.
Oh, completely useless. The diagnostic landscape there is incredibly murky.
Murky is a great word for it, because you, the listener, you have to understand that muscle diseases or myopathies are just rare and wildly heterogeneous.
Yeah, you're dealing with hundreds of different genetic mutations, autoimmune attacks, metabolic failures.
Right. And despite all these totally different root causes, the body manifests them with a remarkably limited set of symptoms,
I mean, for the most part, it just looks like general weakness.
which is so vague.
It is. That generic presentation is the central challenge here. The neurologist has to take a symptom as vague as, I feel weak, and somehow trace it back to a single misfiring protein.
Or a highly specific rogue antibody, right?
Exactly. You are flying blind unless you know how to read the landscape. And that is where pattern recognition becomes like the most critical tool in medicine.
Which brings us to the core of today's deep dive. We are unpacking the framework neurologists use to actually solve these mysteries.
It's fascinating stuff.
It really is. We're guided today by the research of Dr. Margarita Malone, specifically her comprehensive article, A Pattern Recognition Approach to Myopathy.
Which is a fantastic resource.
Yeah, we want to look at how doctors build a diagnostic map out of seemingly invisible clues. Because, the stakes here go far beyond just putting a name on a chart.
Oh, the therapeutic landscape has shifted dramatically over the last decade.
Right, it's not just about managing decline anymore.
No, not at all. The field has yielded extraordinary innovations, gene-specific therapies, antisense oligonucleotides, enzyme replacements. Wow.
Yeah. Accurate diagnosis can unlock highly targeted treatments that completely alter the natural history of a disease. So finding the exact pattern means the difference between a patient, say, slowly losing their mobility and a patient receiving a therapy that just arrests the disease in its tracks.
Exactly. It's life-changing.
So let's look at how that pattern recognition actually begins. Because before a neurologist even tests a patient's strength or brings out the reflex hammer, they are building a timeline.
The clinical history is everything.
Right. The first major clues come from the timing of the weakness and the seemingly unrelated triggers surrounding it. I like to think of it like troubleshooting a crashing computer system.
Oh, that's a good analogy.
Yeah, like knowing that the system crashed is pretty much useless. But knowing it only crashes when you open one specific program while the cooling fan is running, that gives you the actual diagnostic signature.
Right. The rate of disease progression categorizes the problem immediately.
Okay, so walk us through the timelines. Let's start with an acute onset.
So, consider an acute onset where severe weakness develops over just days or weeks. And it's often accompanied by rhabdomyolysis.
Rhabdomyolysis, that's a big word. That's when the skeletal muscle tissue rapidly breaks down, right?
Exactly. It breaks down and dumps myoglobin into the bloodstream. It actually turns the urine a dark cola color.
Wow, that sounds terrifying.
It is a crisis. That violent, acute timeline points directly to a toxic exposure, a severe viral infection, or a profound metabolic crisis.
Like the muscle literally runs out of energy and begins consuming itself.
Right, exactly.
Okay, so acute is a crisis, toxic, or metabolic. But what if the weakness develops subacutely over, like, weeks to months?
A subacute timeline typically suggests an acquired immune-mediated myopathy.
So the immune system is the culprit.
Yeah, the immune system has lost tolerance and is actively infiltrating and attacking the muscle fibers.
And conversely, if you see a slowly progressive course weakness creeping up almost imperceptibly over years or decades, what's that?
That strongly points to a genetic inherited muscular dystrophy. The genetic flaw was, always there, slowly degrading the tissue over a lifetime.
But biology never makes it that simple, does it?
Never.
Yeah, there is an exception in the sources that seems like a total diagnostic trap. Multiple acyl-CoA dehydrogenase deficiency, or MADD.
Right. MADD perfectly illustrates the danger of relying on just one data point. It is an inherited genetic metabolic disorder.
But hold on, before we talk about how it hides, what exactly is failing in the body with MADD? What even is acyl-CoA dehydrogenase?
So it comes down to mitochondrial function. Acyl-CoA dehydrogenases are crucial enzymes inside the mitochondria. They're responsible for breaking down fatty acids.
Okay, so it's about energy processing.
Right. When your muscles are at rest or during prolonged endurance activities, they rely heavily on fat for energy.
Makes sense.
If you lack these enzymes, the metabolic pathway is just broken. The cell starves because it cannot access its own fuel reserves.
And then toxic intermediate metabolites build up in the tissue.
Precisely.
And the really insidious part is how this genetic time bomb gets triggered. The text notes that late-onset MADD can be set off by everyday medications.
Yeah, specifically sertraline, a very common antidepressant.
That is wild. How does an antidepressant trigger a muscle disease?
Well, the metabolic pathway in someone with late-onset MADD is already incredibly fragile. It's operating at bare minimum capacity.
Hanging by a thread.
Exactly. So you introduce a compound like sertraline, which can subtly alter mitochondrial function or increase metabolic demand, and you push that compensated state into complete failure.
The system crashes.
Yep. But if you recognize the pattern that this subacute failure was triggered by a specific medication in a patient with an underlying metabolic vulnerability, the treatment is remarkably simple.
Right. The text mentioned they show dramatic clinical improvement just by supplementing with riboflavin and coenzyme Q10.
Yeah, it's amazing. You are basically providing massive amounts of the specific cofactors those defective enzymes need to function. You're forcing the metabolic roadblock open.
Wow. It really highlights why triggers are just as important as the timeline. You have to look at the environmental stressors that force the muscle to fail.
Dietary triggers are a huge one, too.
Yeah, like the sources describe patients who experience temporary paralysis just after eating a carbohydrate-rich meal.
Right. A heavy carbohydrate load is essentially a metabolic stress test. In a condition called hyperkalemic periodic paralysis, eating, say, a large plate of pasta or French fries triggers a massive insulin spike.
Okay, and insulin does what?
Insulin drives potassium into the cells. For most of us, that's totally fine. But these patients have a genetic mutation in their sodium channels, a sodium channelopathy.
So the sudden shift in potassium messes with the electricity of the muscle.
Exactly. It alters the resting membrane potential of the muscle cell, causing the electrical signaling to short out entirely. The muscle becomes unexcitable, leading to paralysis.
That is so specific. Or, looking at surgical history, a family history of severe reactions to general anesthesia is a massive red flag for malignant hyperthermia.
Yes. That's a mutation in the RYR1 gene, which controls calcium release in the muscle.
Right, so you expose that mutated receptor to certain anesthetic gases, and it just floods the muscle cell with calcium, causing a sustained, massive contraction that generates lethal amounts of heat.
It's a true medical emergency. So the clinical history, the timelines, the triggers, they often write the diagnosis before the physical exam even begins.
But eventually, you do have to map the physical damage. Once the timeline and triggers establish the when and why, the physical exam maps out the where.
The geography of the weakness.
Yes, and the exact geography of which muscles fail and which ones remain perfectly strong acts as a highly specific fingerprint for the disease.
Neurologists analyze very distinct distributions. They look at whether the pathology targets the proximal muscles, the large limb girdle groups around the hips and shoulders.
Right, versus the distal muscles in the hands and feet, and they look for symmetry.
Inclusion body myositis, or IBM, is a prime example of this highly specific geographic pattern.
IBM is the most common acquired myopathy in people over 45, right?
It is, and it has a signature asymmetric pattern of destruction. It preferentially attacks the deep finger flexors and the quadriceps.
Okay, so how do you test for that? Because testing for that requires more than just asking a patient to squeeze your fingers to gauge grip strength.
Oh, a general grip test will completely miss the nuance. The neurologist will ask the patient to supinate their forearm.
So turn the palm facing the ceiling.
Right, palms up, and then attempt to make a fist. IBM pathology often targets the specific motor units of the flexor pollicis longus and the deep flexors of the index and middle fingers.
Wait, so because of this highly specific cellular vulnerability, a patient might be physically unable to flex their thumb and index finger to make that fist.
Exactly, but their pinky finger on the exact same hand will curl inward with normal strength.
That is incredible. Your thumb is paralyzed, but the pinky right next to it is perfectly fine.
It's that level of granularity that makes the diagnosis.
But the physical map doesn't stop at the muscles, does it? Neurologists are looking for clues in the architecture of the entire body.
They are. The exam goes far beyond just muscles.
Yeah, the article mentions Christmas tree, cataracts, rigid spines, and even high-arched palates. But let me push back here on behalf of the listener. Why would a muscle disease cause cataracts? Aren't these strictly muscle problems?
It's a great question. It's because the genetic mutations driving these diseases rarely confine themselves to just skeletal muscle. The blueprint is flawed everywhere.
Okay, so it's a systemic issue.
Right. For instance, myotonic dystrophy type 2 is characterized by a specific RNA toxicity. The mutated gene produces abnormal RNA that clumps up inside the cell nucleus.
And that interferes with the production of many other proteins.
Exactly. In the lens of the eye, this disrupts normal protein synthesis, leading to the formation of iridescent, multicolored opacities. They literally look like needles on a Christmas tree.
Wow. The sources also highlight skin blistering or severe scarring, like keloids.
Yes, that's another big one.
If you've ever dealt with a mystery illness, you know the frustration of symptoms that seem totally disconnected. Why would a muscle disease cause your skin to blister?
It comes down to what we call multi-system proteinopathies. Biology relies on shared resources. Take a protein called plectin.
Plectin.
Plectin acts as a critical structural crosslinker. It is basically the biological glue anchoring the cytoskeleton inside skeletal muscle cells to the outer membrane.
So it allows the muscle to contract violently without, like, tearing its own cellular structure apart.
Precisely. If the plectin gene is mutated, the mechanical stress of contraction shreds the muscle fiber.
And how does that connect to the skin?
Well, exactly the same principle applies to the skin because plectin is also heavily expressed there. It anchors the outer layer of the epidermis to the deeper dermal layers.
Oh, I see.
So the mechanical stress of simple friction just rubbing the skin causes the layers to shear apart because the biological glue is defective.
And the patient develops severe skin blistering alongside their muscular dystrophy.
Right. Recognizing that skin blister prevents years of invasive, misdirected neurological testing.
But what happens when that physical map is completely ambiguous? Let's say the patient just presents with generic, symmetrical proximal weakness in their hips and shoulders.
It happens all the time.
Yeah, like no skin blisters, no cataracts, no asymmetrical finger weakness. That could be a toxic statin reaction, a dozen different limb girdle muscular dystrophies, or an immune attack.
Right. The clinical fingerprint is blurred.
So how do you find a pattern when the physical exam gives you nothing specific?
When that happens, the pattern recognition has to shift to imaging and cellular pathology. This is where muscle MRIs become invaluable.
So you're putting the muscle in the scanner, but you aren't looking for a torn tendon.
No, not at all. We are looking at the geometric pattern of tissue death. Over time, as muscle fibers die in chronic myopathies, they're replaced by fat.
Okay.
On a T1-weighted MRI, healthy muscle looks dark gray, while fat shows up as bright white.
And different genetic mutations cause that bright white fatty replacement to happen in distinct geometric patterns within the muscle belly itself.
They absolutely do. In collagen 6 muscular dystrophies, the MRI reveals an outside-in pattern.
Outside in, what does that mean?
Well, collagen 6 is an extracellular matrix protein. It forms the scaffolding outside the muscle fiber. So the degeneration typically begins at the fascial boundaries, the outer edges of the muscle.
And slowly works its way toward the center.
Right, creating a distinct tigroid or target-like appearance on the scan.
Oh, wow.
Conversely, in conditions like LGMDR21, the protein defect involves the internal sarcomere structure. The fatty replacement starts right in the center of the muscle belly and spreads outward an inside-out pattern.
It's like crop circles inside the thigh muscles. It directs a geneticist exactly where to look.
It really does. It's a huge clue.
But imaging still has limits. The article details a fascinating case study of a 70-year-old man suffering from terrible pain and frequent falls.
Ah, yes. This case is a perfect example of when to use a biopsy.
Crucially, his creatine kinase, or CK levels, which usually spike dramatically when muscle fibers rupture and spill their contents into the blood, were completely normal.
That normal CK level is the crux of the case. It suggested they weren't dealing with massive, acute muscle fiber necrosis.
So they needed to look at the tissue directly. But selecting the biopsy site is kind of an art form, isn't it?
Very much so. They deliberately bypassed his quadriceps, which maintained normal strength, and chose to biopsy the gluteus medius, a hip muscle that actually showed clinical weakness on his physical exam.
Because if you biopsy healthy tissue, you just find a healthy pattern. You'd find nothing.
Exactly. You have to go where the disease is active. In the weak gluteus medius, the pathologists found isolated amyloid myopathy.
And amyloidosis involves misfolded proteins that clump together to form toxic deposits, right?
Right. And these amyloid deposits were sitting in the connective tissue and the walls of the blood vessels within the muscle, rather than tearing the muscle fibers apart.
Which perfectly explains the normal CK levels alongside the severe pain and weakness.
Exactly. It all fits together once you see the tissue.
But here's a logical question for you. If we have whole exome genetic sequencing capable of reading a patient's entire DNA code, and we have AI analyzing MRI data, why on earth are we still subjecting patients to painful surgical muscle biopsies?
It's a fair question. Genetic panels have absolutely revolutionized the field, but they have two massive blind spots.
Okay, what's the first one?
First, genetic tests cannot diagnose acquired diseases. If a patient has inclusion body myositis or an immune-mediated necrotizing myopathy, their genetic code is flawless.
Because it's not a genetic problem.
Right. The pathology is driven by inflammatory cells, like T cells and macrophages, actively invading the tissue. The DNA is the blueprint of the house, but if an arsonist is actively burning the house down, studying the blueprint won't tell you what happened.
That's a great way to put it. You have to inspect the physical crime scene.
You have to actually see the inflammatory cells actively attacking the fibers under the microscope.
And what's the second blind spot?
Furthermore, even when we sequence the DNA for genetic diseases, we frequently uncover a variant of uncertain significance, or a VUS.
Basically a typo in the genetic code.
Yeah. But every human genome contains thousands of harmless variations. Just because we find a typo doesn't prove it's the typo causing the disease.
Right. It could just be a coincidence.
Exactly. So to prove causality, we often have to biopsy the muscle, stain it, and demonstrate that the specific protein dictated by that gene is physically missing or malfunctioning in the tissue itself.
So the biopsy bridges the gap between theoretical genetics and clinical reality.
Yes, it's still absolutely essential.
Which brings us to the ultimate states of this pattern recognition. Why does the nuanced difference between like an outside-in MRI pattern and an inside-out pattern matter so much? We touched on it earlier, but the implications go far beyond giving the patient a satisfying answer.
It's fundamentally about anticipating the future.
Right. Identifying the precise pattern of a myopathy is about intervening before catastrophic complications arise.
Take LMNA muscular
The
dystrophy.
LMNA gene, yeah.
That gene codes for lamin AC, proteins that form the structural scaffolding of the nucleus in almost every cell in the body. If you use pattern recognition to definitively diagnose an LMNA mutation, you're doing much more than explaining why the patient's skeletal muscles are weak.
You are identifying a patient at a massive risk for sudden cardiac death.
Exactly. Because the scaffolding of the nucleus in their heart muscle cells is also failing under the constant mechanical stress of a beating heart.
Wow. So that specific diagnosis mandates immediate, aggressive cardiac screening.
Yes, it often leads to the prophylactic placement of a pacemaker or an implantable defibrillator. You are literally preventing a fatal arrhythmia simply by reading the pattern in their skeletal muscle.
And conversely, precise diagnosis prevents the harm of toxic treatments. Like if a genetic myopathy mimicking an immune disease goes unrecognized, like the MADD case we discussed, a patient might spend years on heavy immune-suppressing steroids.
Which is devastating. They endure bone density loss, stomach weight gain, severe metabolic damage, all for a medication that has absolutely zero chance of working.
It's tragic. But there is a bright side, too. We are also entering an era where precision diagnosis dictates precision gene therapy.
Oh, absolutely. If you can definitively prove a patient has Pompe disease, which is a deficiency of the acid alpha-glucosidase enzyme, we now have enzyme replacement therapies.
Or if they have Duchenne muscular dystrophy driven by a highly specific exon deletion, we have exon-skipping drugs.
Right. We can target the exact molecular mechanism, but only if the initial pattern recognition points us to the right mechanism.
It all hinges on how well we can read the body's hidden signals, and the boundaries of how we read those signals are expanding rapidly.
They really are. Technology is moving fast.
Yeah, we've focused heavily on human neurologists looking at MRI scans and biopsies, but the research points to artificial intelligence entering this space, finding patterns that human biology simply hasn't equipped our eyes to see.
The application of AI here is pushing diagnostics into a predictive realm.
It's wild. The data shows that AI algorithms are now being trained on standard ECGs, just a standard tracing of the electrical depolarization and repolarization of the heart.
Right, a very basic test.
Yeah. But the AI analyzes the microvoltages and the tiny slopes of the T waves to predict a patient's biological age.
And when researchers ran the ECGs of those LMNA muscular dystrophy patients through the algorithm, the AI calculated a biological age significantly older than their chronological age.
Even before traditional heart problems appeared.
Yes, the AI is detecting mathematical markers of cellular senescence and early structural degradation in the electrical rhythm itself.
And the truly profound part is that the AI detects this accelerated aging in the heartbeat long before any traditional echocardiogram or human cardiologist can spot a physical problem with the heart muscle.
It's seeing the invisible.
The old X-ray machine of simple, visible diagnosis might be obsolete in neuromuscular medicine, but it's being replaced by algorithms capable of reading the microscopic deterioration of our cells.
It's a completely new paradigm.
It really is. And it leaves you wondering, if an AI can look at the invisible mathematical slopes of a standard heartbeat to reveal that your muscles are secretly rapidly aging, what other hidden biological patterns is your own body broadcasting right now that we simply don't have the algorithms to read yet?